Everybody. My name is Vigneswaran. I'm a urology resident at UIC in Chicago, and it's my pleasure to introduce Dr. Crivellaro. Dr. Crivellaro is the director of our robotic surgery training program at our department, and he'll be talking today about the indications and outcomes of single-port robotic surgery.
Thank you very much, Harry. Welcome, everybody. Let me share my screen. And also, I really want to thank UCSF to putting this program of seminars together. Kudos to them. I really believe it's a great initiative and very helpful, especially in this very particular time that we're living. So they asked me to start with disclosure. And I will start with the first disclosure. I am Italian, as you might have guessed by my thick accent. And also, I am a consultant for Intuitive. Now, being Italian, I never miss an opportunity to showcase my beautiful country. God knows if now it needs it more than ever. I was born and raised in Torino, which is a nice city in the northwestern part of the country, which you might know if you are a skier, because we hosted Winter Game in 2006. And if you're a football fan, you definitely know Torino because it's the home of the best football team ever assembled. And this is an unbiased opinion, which goes by the name of Juventus. Torino is also infamous for a car factory, which is called Fiat, which, as you know, stands for Fix It Again, Tony. So having said that, today I was asked to talk to you about the new single-port robotic platform and its indication and outcomes, early outcomes in urology. Now, I'm going to try to talk about this platform from a very specific standpoint, which is the standpoint of an early adopter, a surgeon who was able to secure this unit in December 2018, very early in the game. And after that, it was facing a choice between cherry-picking cases or just keep calm and go all in. And I decided for the second option. And since then, 100% of my cases, robotic cases, have been single-port. As a matter of fact, I was lucky enough to assess this technology in over 200 cases so far, and perform pretty much every case that is robotically doable in urology. And this brings me to my first poll question, which I really invite you to answer. We're gonna address all these answers during the Q&A section at the end. It's a very simple question. Is your program or hospital using SP currently, yes or no? So, as I was saying, being able to perform all my cases with the single port give me a very unique opportunity. The opportunity to try to answer the two big questions that always come with new technology, which is the what and the why. When it comes to the what, I like to show this short clip about the single port, essentially to help people understand how much different is this robot. It's a single arm robot which holds a 27mm robotic cannula through which it delivers a flexible camera, 8mm in size, and 3 6mm robotic instrument. Now, I want you to understand that you don't want to replicate whatever you were doing with the multi-port platform with this. Because yes, it's gonna work, but if you do that, you won't even scratch the surface of the potential that this platform has. And this brings me to the actual second big question, which is the why. Because you would ask, why am I supposed at this point to move away from the multi-port platform, which is my comfort zone? I know it works, I have good outcomes with that. So why should I move from there to a new platform? There are a lot of good answers to that question. Actually, this brings me to the second poll question. So do you think right now, knowing what you know before this lecture, if the SP can add values to your robotic procedure? Again, yes or no? Please go ahead and answer the question. And so I'm going to try to answer the why question, explaining to you why I made that decision almost a year ago. Essentially, I wanted to face and solve some of the problems and limitations that we've been dealing with the multiport. And one of them being the needs of evolution. I really believe that robotic surgery didn't really evolve during the last 5 to 6 years in urology. I didn't see any major breakthrough. And simply because I believe we exhausted all the potential of the technology. And yes, we have seen over time multiple updates of the same robot, of the same technology. But this is different. This is not the last update. I strongly believe this is the first generation of a completely new robotic platform, which will lead us to different places, and I believe to better places. And so it's a unique opportunity to try to make robotic surgery in urology evolve and progress. And why I think the SP will be instrumental in doing that? Because there are a lot of new things that this platform is bringing in the field. First of all, we're moving from a rigid camera to a flexible camera. And you can move this flexible camera in many different ways. With camera control, you can actually control the tip of the camera and move it in any direction you want. With camera adjust, you can go in, out, right or left. You can rotate right, rotate left. And with the relocation pedal, you can move the entire platform and the camera pretty much in every quadrant of the abdomen. But this is just the start. We also have another new feature called the relocation, around the clock relocation. Essentially, you can rotate the platform along the single arm axis, which allow you to have the camera at 12 o'clock, 6 o'clock, 3 o'clock, or 9 o'clock, wherever you think it's necessary for the task they're trying to achieve. And that also helps you to have different kind of traction because you move the instrument too, together with the camera. This is an example of a good use of relocation around the clock. This is a prostatectomy, and I'm about to access the posterior plane between the prostate and the rectum. And so what I did, I just rotate the camera at 6 o'clock, and that gave me a very good visualization of the denouvier and the plane between the prostate and the rectum. And on top of that, I'm able to put very good traction with the Cadier, which is at this point at 12 o'clock, and progress with the dissection with the instrument at 3 o'clock, which is the Caesar, and then 9 o'clock, which is the bipolar. And so again, this is just an example. The nice thing of the around the clock relocation is that it can be performed by the first operator at the console or by the assistant at the table. The other new things is the multi-quadrant relocation. The multi-quadrant relocation essentially allows us to move the entire platform anywhere in the abdomen without the need of redocking, without repositioning the patient. This is another example of use of relocation. That's a Boaric, so very proximal urethral stricture. The ureter is ready to go, but now I have to go down and I'm relocating into the pelvis in order to grab the bladder and then relocate up with the entire platform in order to secure the bladder to the psoas. So all these movement, proximal to distal, which we do for ila ureter, reconstructive cases, nephryu, and so forth, they're extremely easy to perform with a single port with no need of redocking or moving the patient. And finally, there is something that we call the navigator. The navigator is a little icon that you have at the bottom of your screen, which essentially gives you the real-time position of relative position of instrument and camera. So that's extremely helpful to be respectful of the quadrants and of the working space. But not just that, it's going to give you warning. For example, if your instrument hit the edge of your working space, the instrument itself in your navigator will turn orange. And the camera, it turns green when you reach what we call the Cobra mode, which is essentially the best possible position of the camera relatively to your instrument. So the best possible visual control of your instrument. So this is just a short description of all the new things we have available with this. And you can actually realize that the value that we're adding is simply to introduce new features, which I believe is the only way to evolve and to progress in what we do. And these new features are extremely instrumental to face and solve another problem that we've been dealing with the multiport, which is the fact that the multiport platform is, as a matter of fact, less functional in small spaces. We all know that. And because of that, the vast majority of robotic surgeons, they've been performing their procedure intraperitoneally. Now, that's not a problem per se, but as urologists, we know that not using other accesses than intraperitoneal, we give up some benefits, like no need of TBERG, like faster bowel function return, like working in a contained space, which is always helpful for whatever can happen after the surgery. We know that non-intraperitoneal approach can provide less pain and the possibility of an earlier discharge. And specifically for SP, regarding these last 2 points, we were able to show that the extraperitoneal approach for prostatectomy is associated with shorter post-op hospital stay and decreased need of post-op narcotics when compared to intraperitoneal approach. This is a paper we published last year in December on the Journal of Urology. So what I'm trying to say is that SP really is giving you the chance to move away from the classic intraperitoneal approach whenever is indicated and start exploring different accesses like the extraperitoneal for prostate, the retroperitoneal for kidney, transperitoneal. Red sparing is a very interesting arena, which I recently started to explore, which fits perfectly with the single port, and transvesical approach. And so this is the third poll question. I'm very interested to know in your hospital what approach you use for your kidney robotic surgery, if it's transperitoneal, anterior retroperitoneal, posterior retroperitoneal. And you'll have a very similar question for your prostate surgery. Why am I asking this question? Simply because I believe that the vast majority of robotic surgeons in the United States are going intraperitoneal, but a good number of them, they would love to go retroperitoneal for kidney because they know how much is useful, but they just don't do it because it's a little bit cumbersome with the multiport. Yeah, so I'm looking now, is 81% transperitoneal as I suspected. Okay, good, that's very good. And I'll show you one retroperitoneal partial nephrectomy with the single port in order to show you how big is the potential with this platform for this particular approach. So as you have seen, you essentially make a 2.5 to 2.8 centimeter incision, which is very small, and then you drive the entire platform inside your incision. Once you're inside, you deploy your instrument, and all of a sudden it looks like you're working in a big field, but it's not. A good number of times is not bigger than a baseball. But the fact that you're coming in through a single incision and you open your instrument inside makes it look bigger because essentially it completely cancels the problem of clashing outside or inside of the space that you developed. So retroperitoneal approaches, you know, the hardest part is orientation, and there's a little bit of learning curve with that, but once you got it, it's extremely fast. We have the psoas down there, 6 o'clock, which is our main anatomic landmark when you start. Once you find that, you stay outside of Gerota and you go straight for the pedicle. Right now, we already have a glimpse of the artery right there. It's extremely fast. That's one of the nicest thing about the retroperitoneal approach. The artery is literally right there. Now, I'm helping myself with the retraction. The assistant is essentially doing almost nothing during the whole procedure. I'm helping with the retraction with the bipolar, which is at this point at 9 o'clock and is lifting up. And I'm progressing with the Caesar at 3 o'clock and the Cadier at 6 o'clock with the dissection. For suction, as you can see, I'm using a 14 French Foley. The whole case is performed with the air seal going on and the suction constantly on. So now that I have found the artery and it's nicely dissected enough to put the bulldog on, I move on toward the kidney. I open Gerota. And again, I manage my own traction. So the bipolar is lifting up right there. The Cadier is doing counter traction, so pulling down. And the Caesar is progressing with the dissection. One big advantage of the single port with retroperitoneal approach for kidney is that you can either treat lesion in the anterior face of the kidney or the posterior face. It really doesn't matter where the lesion is located, lower pole, upper pole. You know that with the multiport, there was a limitation because anterior face, upper pole, you can do it, yes, but it's extremely, it's a big struggle with the multiport. With the single port, that is not a problem anymore because again, you're coming through a single incision. You can relocate up, down, proximal, distal, whatever you want. So now I keep cleaning the kidney. This was actually a 3.5 centimeter endophytic, peripheral, but completely endophytic lesion. So I really want to have a nice view of the entire kidney before I check with my ultrasound probe. So the camera for now is still at 12 o'clock, okay? Because I don't need to have a different view. I think I have a good control of the entire kidney like that. Now, that's the probe that is introduced through a 12 trocar, which is through the same incision. The concept is called, the setup is called Sidecar, and we'll talk a little bit about that eventually in the presentation. So now I can see the lesion with my probe. I just mark my, my kidney, get ready for the resection. So the probe is coming out in a second. And now I start thinking about what's the best setup for the resection. And most of the time, the best setup for these cases is with the camera at 6 o'clock, because you're gonna have better traction on top of your head and because you have a better view. And that's exactly what I'm about to do. So in a second, I will start relocating with the so-called relocation around the clock, which is what's happening now. So essentially, I'm rotating the platform clockwise, 180 degrees. So the camera that used to be at 12 o'clock is now at 6 o'clock. Now, the camera is, I didn't switch the camera yet, but believe it or not, I could perform the whole case the way I am now, which is like doing surgery upside down. The only thing is that the anatomic landmarks are not that natural. So I switched the camera from above to below. And now I have a very nice view of my lesion. And after the assistant switched the monopolar with the bipolar, I can get ready. So the Cadier is now at 12 o'clock, the Caesar is at 3 o'clock, and the bipolar at 9 o'clock. And I'm getting ready for the assistant to do one of the few things he's gonna do throughout the entire case, which is essentially positioning the bulldog. The artery is right in front of me, is a straight shot. I put the traction myself, and there you go. The bulldog is coming in, boom, and I'm ready to go. So I start my dissection, and again, the Cadier is still up here, lifting up the gerotas and the perirenal sac in order to give me space. Now, in a second, the assistant will get in with the rigid suction, which I normally don't use for these cases, simply because I love to have the flexible suction and to be able to control the suction myself. In the meanwhile, I start the dissection. Again, it's an endophytic lesion, so I have to go quite deep before I find the enucleation plane. The flexible suction is now in, and as you can see, I can really control the suction with my bipolar and help myself with contraction with the cardiac. So I keep cutting, keep looking for the plane, and it's really the three instruments with the single port are actually working at the same time. So it's not just one instrument putting traction and the other two instruments progressing with the dissection. And the nice thing about single port versus multi-port for the retroperitoneal cases like this is that you have three very functional instruments available. Normally with the multi-port, yes, you can fit 4 arms in the retroperitoneal space, but it's a lot of a struggle. And typically you don't use the 4th arm that much. You're not able because there's too much clashing. With this, there's no clashing at all. So all the 3 instruments are extremely functional. So now I have found the enucleation plane there. And as you can see, I actively use the cardiac for dissection. And then I advance my suction, my Foley, and keep cutting and keep getting the lesion. It's a nice enucleation plane. It was completely endophytic, but we didn't cut too much healthy parenchyma on top of it. And now I'm ready to go for the reconstruction part. So at this point, the assistant will switch the instrument, will give me 2 needle drivers at 3 and 9 o'clock. And there you go. Let me skip a little bit for the sake of time. So this is the 3O that I normally use for the first layer of my reconstruction. As you can see, the sewing part is a little bit different because you might have noticed already that you don't really have a wrist. You have an elbow with this instrument, and you have a shoulder, but you don't have a wrist, which doesn't mean you're going back to laparoscopy at all, but it means that the movements that you have to do in order to sew, they are a little bit different than with the multi-port, but really the adjustment you need to do is very minimal. Those are the 2O that I normally use to close the defect. And in this case, we've been using the 12 side cut, which again is through the same incision. So this is pure single incision surgery to pass the suture in. Although if you don't want to use the 12 side cut, like in case you're planning not to clamp the artery, you can put the suture through the robotic trocar itself. So now I'm done. I'm lifting up with the cardiac, and the assistant is coming in to get the bulldog out, and that's it. So that's another question that I would like to ask, because the same concept for the kidney applies for prostate. So I would like to know what approach you normally use for your prostate robotic surgery in your hospital. The anterior classic intraperitoneal approach, the posterior so-called ratio-sparing intraperitoneal approach, the extraperitoneal, or the transvesical. So I would love to know which is the case, although I believe the vast majority of hospitals are now using the anterior intraperitoneal. So moving forward, oh, there you go. 79% of people are using anterior intraperitoneal. Okay, very good. So I'm just going to give you a couple of minutes of the extraperitoneal prostatectomy video, simply because otherwise we're going to run out of time. But it's the same concept. So we have a 2.5 centimeter incision. We enter the space that we previously created. Once we are in, we just deploy our instrument, and you can appreciate how small is this incision through these pictures. So now I'm essentially using the relocation to center the arm and then to navigate inside. And once I'm inside, I can deploy the instrument, flex the camera, and I won't have, as a matter of fact, any conflicts or clashing after this. And at this point, really, extraperitoneal, it's very nice. You don't need to drop the bladder. The pelvic floor is already there. You have, again, 3 instruments available for traction and dissection. In this case, I also use either an NG tube or a 14 French Foley for suction, for flexible suction, so that way I can control the flexible suction myself. And the technique is really not any different than a normal retropubic or extraperitoneal prostatectomy. I'm cleaning the fat now, and now they're introducing, in this case, an NG tube. So the prostate is right there, and I will be getting ready to open the endopelvic fascia very soon. Now, let me skip a little bit. I want to show you the bladder neck part after I open the endopelvic fascia. That's the DVC. All right, so bladder neck, it's very interesting because, see, I can put traction and control the suction at the same time with my 3 instrument, and I have no need of really the assistant helping me. So now that I got in, I just got the catheter, I can grab the catheter with the cadia, which is being switched from 6 o'clock to 9 o'clock, and keep and approach the posterior bladder neck. And again, no traction from outside. Everything is essentially controlled by the first surgeon. So the bipolar at 6 o'clock helped me push down on the bladder, and I progress with the dissection with the scissor. And if I have urine coming into my view, I just move my NG tube and leave it there on top of the bladder neck in order to keep the field dry as much as I can. Now I'm looking for the SV. Again, traction and suction at the same time. Just pulling down, the non-VA is in view. And keep going. And once I have cut through the non-VA and I see the SV and the VAS, I'm actually going to change traction, because right now the cadia is up here at 12 o'clock. You can see it in the navigator, and it's holding the catheter. But at this point, really, that traction is not really helpful for me. So what I'm going to do, I will grab the SV and actually the VAS before with the cadia. There you go. So I drop the catheter, I grab the SV with my cadia, and I push down on the bladder with my bipolar, and I keep progressing with the dissection. Now, I have 3 instruments working in a very small space. This is no more than 2 centimeter space. And regardless, I don't have real trouble or conflicts or clashing of the instrument, because again, it's single port. And so I can really progress into my dissection in small spaces like this with no problem at all. And I can play with the traction with the bipolar and the cadia and make my way through the SV. All right, so enough of surgical videos. That's what happened to my practice since I started using SP. That's what I'm talking about. Essentially, I moved from 100% overall intraperitoneal cases, regardless they were prostate, kidney, whatever, which is in line with, I understand, you guys are doing in all your hospitals. So I moved from that situation to a combination of intraperitoneal, extraperitoneal, retroperitoneal, intravesical, and ratio-sparing cases. Simply because the SP made those accesses and those approaches easier, more approachable, more easier essentially to perform. Because I already tried before with the multiport to do something different, because I know those approaches are associated with benefits, but I just gave up because it was too cumbersome and too difficult. I really believe the SP make these accesses easier to perform. And that's exactly the value that we're adding. We are offering different anatomic approaches to finally tailor the procedure to the patient and not the other way around, which in turns help to really try to tackle one of the major topics of minimal invasive surgery, which is the invasiveness. Because we say we are minimal invasive with the multiport, but are we? In other words, do we have any room for improvement? I really believe so. And when I say invasiveness, I don't mean just the cosmesis part. That's just the tip of the iceberg. I mean pain control. I mean length of stay. I mean faster recovery. And yes, sorry, but for some reason it's acting. We can perform very complex procedure through small incision, and that's cool. But we can also impact on pain and length of stay. That's a paper that we recently published in European Urology. It's a comparison between single-pore prostatectomy and multi-pore prostatectomy, showing a decrease in length of stay, an increase of patient discharge after one overnight, and an increase of pain-free patient on post-op day 1 in favor of SP. And it's not just us. This is another paper published recently on Journal of Urology by Jeff Nick's group in the University of Alabama. Same comparison, shorter length of stay for single port, although not statistically significant different. And those are Ronnie Abaza's number from Ohio Health. He was able, through the single port, to decrease the mean post-op score by 15%. And also, he's been having this nice same-day discharge protocol for years now. And since he introduced the single port, he was able to send patient home with the single port same day 88% of the time, in comparison with 50% of the time with the multi-port. So if you ask me, and according with the early data that we have in the literature, yes, we are impacting on invasiveness. We are decreasing the invasiveness of what we do. And I really believe that through DSP, we can move toward something even less invasive of what we do now, which I call micro-invasive surgery for a lack of a better word, really. And this is because we're doing different things. We are using more extraperitoneal, retroperitoneal approach. We are dissecting less than before. We are using lower pneumo because we're kind of forced to. We're working in smaller spaces. We're going through a single incision. We can create less pain, and we can send the patient home early. So when you put all these together, you realize how much impact you can have on the invasiveness of what you do. There are other values we're adding with SP, really. I believe we're proving the ergonomics of what we do. This platform is smaller, as a matter of fact. We have more space around the patient than before. And the setup is definitely shorter. We were able to save, on average, 15 minutes per robotic procedure because of the shorter setup and because of the easier docking. Now, when it comes to the docking, the platform can come from anywhere around the patient. So there is no more specific setting of the OR based on what procedure you're doing, simply because the single arm can flip 360 degrees around the cart. So once you're close enough to the trocar, you flip the arm in the direction of the organ target, and then it's just one click, and essentially you're done. Another value that I think we're adding is that there is a major effort through this platform to move toward a pure solo procedure robotic surgery, kind of endourology style. And we were able to achieve this because we moved away from the standard setup, which we were using at the very beginning of this experience, the so-called +1. And we started using the floating dock setup or the sidecar setup. I'm sorry, I don't know why my picture they're not showing up. I'm not gonna go into details about this because we don't have time enough, but I can tell you that through this setup, the role of the assistant is really minimal or none. So the first surgeon is really able to have control of most of the procedure. Finally, outcomes. Of course, the value that everybody want to add for their patient is to get better outcomes. Are we getting better outcomes out of this? That's still a question mark. I mean, we're really early in this game. It's really hard to say anything definitive about it. There are very few comparison paper published at this point. There are a lot of series like show and tell paper published, but the only few paper we have, the one that I already mentioned before, they're showing an improvement in some of the perioperative early outcome in favor of the single port, like the pain control and the length of stay. And the other early perioperative outcomes, essentially, there is no difference, which means that the SP is a minimum non-inferior to multiport, which to me is a very good news. This is a new platform. Most of these papers are published based on the first cases done. So through the learning curve, which I believe there is a learning curve with this. And so we'll see what's going to happen in the long term for the long-term oncologic outcome and functional outcomes. So if you ask me, and that was the real title of this lecture, if you ask me, what are the best indications for this platform? I'm going to tell you, based on my experience so far, that this platform really perform better in small spaces. So extraperitoneal approach, retroperitoneal, retio-sparing, transvesical, transperineal. You can use it in bigger spaces, intraperitoneally. I believe that's the best way to go when you start doing this. But you'll soon realize that you can do a great job through these approaches, which, as I said before, we know they are associated with some very big benefits. And so I like to say that in some ways, for the extraperitoneal, retroperitoneal approach, this is kind of back to the future for urologists, because when I was trained, most of the procedure we were doing, they were open and as a resident, and we were always going extraperitoneal for prostate and always going retroperitoneal for kidney. And then the robot came along, laparoscopy came along and the robot, and so we were kind of forced to give up those approaches and go to the peritoneum. We were not super happy about that, but we did that because the robot was adding some different values. And now we have finally the chance to go back to the nice approaches that we were using before, with on top of that all the benefits that the robot can bring to the minimally invasive surgeries. In terms of early outcomes, what I can tell is that this platform can provide less invasiveness in terms of pain and length of stay. And for all the other outcomes, for now, I can tell is not inferior, which is kind of what one of the goal of this platform is, to just decrease the invasiveness of what we do, not jeopardizing or compromising the good outcomes we were already getting before. So I think this is a good overall outcomes for this platform so far. And that's my last poll question, which is exactly the same as the one that I asked at the beginning of my presentation. So do you think SP can add values to your robotic procedure? I just want to make sure that I was able to deliver why I do believe the SP is here to stay, and why I do believe that this platform is adding some very important values to what we do. So I was asked to put up this slide. Okay, good. 95% of people thinks that SP can add values. Good. That means that I did a decent job at least. I believe we do have still 20 minutes, Hari.
Yeah, some questions. So one question is, what is the training and learning curve with SP compared to other robotic platforms?
Well, that's a very good question. I believe there is a learning curve mainly associated with the use of the camera. Camera is really different than before. It's a flexible camera, and as I show you in the clip, you can control this camera in many different ways, and it involves using the pedals and the masters as well. So it takes a little bit to learn how to use it and to change your mindset. Because with the rigid camera, really, you don't have a lot of options. So you don't even think about it. But with the flexible camera, you have to think about it, because if you learn how to use it properly, then you can actually take a big advantage of it and have different kind of angle of view that you didn't have before. Another learning curve part, I believe it comes with the use of the navigator, which really helps, because at first you will feel constrained because, again, it's a single port. There is not a lot of swings laterally or in any direction. And so when you reach your limit with your instrument, what you have to do, and the navigator will let you know that, you have to relocate the entire platform in the direction in which you want to keep working. So essentially, it's like dividing your big surgical field in many, many smaller surgical field, and then keep progressing that way, which is one of the reasons why I believe this platform is working great in small spaces. Overall, I don't believe it's a hard learning curve. It's not like going back to square A. It's not like going back to your first robotic prostatectomy at all. We did a human factor study, and that didn't show any difference in terms of human factor variables, which is essentially means how much you're struggling to learn something new. And there was no difference. And in terms of time, procedure time, after the first 10 prostatectomy, we were able to catch up. And we're now essentially below our standard time because mainly of the shorter setup. I hope I answered.
Yeah, I think so. So question, so what are some of the difficulties, if any, you've experienced using the SP? And just to go off that, maybe what was the easiest procedure to transition to with the SP versus most difficult?
Well, I believe that for me, the easiest procedure to start was, we started with intraperitoneal standard anterior approach prostatectomy with a +1. And then we slowly, start exploring different options. In general, I believe you should start with whatever you're more familiar and more comfortable with. And in the beginning, you will inevitably try to replicate all the move and all the dissection technique that you were doing with your multiport, but then slowly you start changing your mindset and you start using the technology in a different way, which I think that's where the extra value belongs. You really can add new things with the combination of new features. It's a process, but I strongly recommend to start with whatever you're more comfortable with, which in most cases is intraperitoneal prostatectomy, simply because that's the procedure that we perform the most in general.
And what would you say the most difficult part is when starting?
I think the most difficult part is to actually change your mindset, because we're so used to use the multiport, and we're so used to the limitation and the problems that comes with it. So we kind of adapted over time to those limitations, and we got used to it, and we start doing things and adapting to the technology limitation. With this, all of a sudden, there are some things that you can do that you couldn't do before, but your brain, it takes a little bit longer time for your brain to catch that. And so you have to remember, for example, that you can flex your camera. You have to remember that you can relocate around the clock and have the camera at 6 o'clock. You have to remember all these things. And so probably that's the hardest part.
So another question, would you consider the cost of initiating SP at a new hospital prohibitive, or is it similar to multi-port platform?
Yeah, we did a cost analysis on our first 50 prostatectomy. The cost of the disposable instrument is slightly higher than multi-port. It's not prohibitive, it's not extremely higher, but is higher. We were able to decrease the overall cost because we decreased the time of surgery and we decreased the in-stay. And so if you consider that, if you put that into the equation, the overall cost of a single port, it becomes similar to a multi-port. Also, I believe when it comes to cost, you have to keep in consideration not just the cost of what you're using, but also the cost of the overnight stay, the time of surgery, and all other variables that are typically not taken in consideration. This is a platform that can really open the way to real outpatient robotic surgery for a lot of cases. I mean, having an SP in a surgery center and being able to perform a good number of cases robotically there, that's a major from a cost standpoint, I think that's a major improvement. So yes, it costs a little bit more in terms of disposable, but I don't think it's prohibitive, and I think there's some extra value even financially that we're adding.
Okay. In terms of the learning curve for the OR staff, could you speak a little bit about that?
Yeah, for the OR, for the scrub nurse, there is a learning curve because the way the robot is draped is different. Is one single drape that needs to go all around the single arm, and it's not super easy to put it on. The instrument itself are different. Every single instrument has a sheath around, so they have to put the sheath around. The scissor, they have disposable tip, which is nice for the surgeon because every case you have a new tip. So essentially it's like having a new instrument for every case, but putting this tip on top of the instrument is actually not super easy. So I found out that was a big part of the training as well. So normally, you know, the company offer training for the OR people as well, and for the surgeon, of course. So, and I think they did a good job. I mean, our hospital, most of our scrum nurses, they're already familiar with robotic surgery in general, so we didn't have any particular problem in moving from multi-port to single port in that regard.
So a question, we're wondering if, since the procedures are slightly different with multi-port, is there a surgical atlas that you know of that highlights the specific differences between single port and multi-port surgeries?
A specific procedure? Ari?
Surgical atlas, sorry, I cut out there. Do you know of a surgical atlas that highlights the differences between single port and multi-port?
So you're breaking off and I can't hear you. Can you just write it down, the question, or show me what question it is?
Yeah, it's in the Q&A, but maybe you can hear me now. The question was, is there a surgical atlas that highlights the specific differences between single port and multi-port that you know of?
Oh, well, I'm not sure there is a specific surgical atlas to show specific difference between the two platforms. You can really, the steps of the procedures, in the end, they're pretty much the same. I mean, if you do a retroperitoneal partial, you've seen it, the steps are the same. You dissect, you go for the pedicle, you go for the artery, and then the difference is that inside every specific step, you manage your dissection differently. Because first of all, there is no interaction with the assistant most of the time. And you do have 3 active instruments in a very small space. And so you start doing things differently. You start being, in my opinion, more efficient because you don't have to rely on anyone. And the amount of dissection you do is less and less because you manage your interaction better. So you don't need to dissect a lot. If you know your anatomy, you just go straight to the target. And so that's the thing, that's the main difference. And but the technique itself really is not changing that much.
Great. I think that's it for questions. I guess just a quick reminder to fill out the lecture evaluation for the organizers. if you could. Maybe
yeah,
I
can put the slide back. Okay, I think is this one. Oh, and for everybody, I do have UIC is an observation center. I mean, of course, now because of the COVID situation, we had to all done for that. But if you want to come and observe cases, or if you need any other information, you can contact me anytime. Also, we are about to start a virtual case observation series, so you're gonna have the chance to watch unedited full videos, and we can do Q&A at the end, so it's just to help everybody to understand how this platform works. And if you have any specific question, you can definitely send me an email or contact me. All right, we're a little bit early, but if there are no more questions, all right, so I believe that's it. Thank you very much, everybody, and I hope to see you soon. Bye-bye.